Thank you, Senator Bishop and colleagues, for joining me. Senator Bishop gave our task force a charge. What can we do to make access to care more affordable and more available? And he mentioned that we have a problem in Michigan. We have, we think, at least 1.2 million without health insurance. And those numbers are probably a little dated. It's changing every day. And we do know that in the last couple of months, the state has enrolled 15,000 new Medicaid recipients per month. So those are people that qualify for Medicaid. But if you're newly laid off or you're working part-time, you're likely not to qualify, and you may join the ranks of the uninsured. So the 1.2 million is dated and is probably growing, and would fit with some of the testimony, the fact that it's growing with some of the testimony that we took on the road. So we have a four-bill package that we've introduced. It was read into the record today. It should be available online soon. But I'm going to give you a quick overview of the elements of the package. And there are four main pieces. One, it includes consumer protections. And you may remember some of this from the debate from last session. And these are important elements that we would install in our laws regulating the individual insurance market, so that if someone is enrolled in a policy and their health condition changes, they can't be re-underwritten or dropped. We would include that protection. We have rules for rescission. Rescission is the issue where a carrier might, based on a review of the initial application, find some flaw in it and might use that as a reason to drop someone from coverage. This is the testimony we heard was this is a problem in some other states, not so much in Michigan, but we should put a provision to prevent that. So rules related to rescission. We also have rules relating to closing books of business, another mechanism whereby a carrier might drop people that are expensive and unhealthy. And then finally, we shorten the exclusionary time for pre-existing conditions to 6 months for all carriers. Right now it's 6 months for Blue Cross, 12 for the others, so 6 months for all. So those are the consumer protections. Secondly, we create a new mechanism to help address the difficult to insure. These are the people in the individual market with pre-existing conditions where their policies are likely to be more expensive. And we create a reinsurance mechanism for that. It will be detailed in the bill, of course, but it involves creating a Michigan Claims Board with representatives from the carriers, and all carriers in the individual market would participate, HMOs, commercial carriers, and Blue Cross. A portion of their premiums would go into this reinsurance mechanism. There would be an attachment point of $25,000 where if a claim in a given year reaches that, this mechanism would kick in. It would be blind to the consumer, to the patient. They wouldn't see a difference. It would be their carrier that would access this mechanism. But by doing this, it smooths out the cost of those difficult to insure and more costly patients. And it thereby gives Blue Cross Blue Shield some relief of their mission as the carrier of last resort. They would retain that mission, but it would be constrained, and expensive patients who hit that $25,000 threshold would then go to this reinsurance mechanism. Then we create two new programs to help create coverage for the uninsured. One is My Access, and the other is My Coverage. And I'll explain the funding mechanism in a minute, but My Access would take advantage of federal dollars, which we would leverage through Medicaid rules, and it would provide coverage for people up to under 200% of the federal poverty level. And I think I should point out that currently Medicaid for healthy childless adults stops at about 43% of the federal poverty level. So you have a large number of uninsured there. And ideally, we would apply for a federal waiver, which would let us craft this program in such a way as to include incentives for healthy behavior and for not smoking and things like that. And there would be a buy-in. Federal laws currently allow certain co-pays and monthly premiums, which we would expect to be part of that program. My Coverage would be for people between 200 and 300% of the federal poverty level. This would be outside of the Medicaid rules, and this would involve the state subsidizing purchases of a new benefits package, which commercial carriers, HMOs, and Blue Cross could offer. The benefits and the makeup of the package would be determined by a board, the My Coverage Board, which would determine what the elements would be and what the subsidy would be, what the qualifications would be to gain the subsidy. There would have to be income screening, and there would have to be crowd-out provisions to make sure that people don't move into this from other programs. But all those are things that can be handled. And by the way, many of these ideas are taken from things that other states have done, not any single state, but from a variety of places. So two new programs that potentially could reach many of our uninsured. It looks as if over half of our uninsured are below 200% of the federal poverty level. So if there was maximum uptake and a maximum funding of this, in theory, this could cover over half of the state's uninsured. The funding mechanism would work like this. Because we've given Blue Cross Blue Shield partial relief of their mission, we would argue that they no longer need their full tax exemption. So they would be asked to pay an assessment to the state, an annual assessment, the amount yet to be determined. Secondly, we would create an assessment on all claims paid by all carriers and all third-party administrators. It would be a broad assessment, but thin. The actual amount yet to be determined. And thirdly, there would be an increase in the hospital QAP. This is the Quality Assurance Program that we now use for our hospitals, which leverages Medicaid dollars. And we have the ability, the state has the ability to raise that QAP sum. So we would have three new funding streams. And there would be some ability to leverage additional federal money. And remember, Michigan gets a favorable match of federal money. And so that would be the funding mechanism that would fund these two programs. So we've surveyed the problem around sites in Michigan. We took testimony from the public and from county health plans to learn what they're doing, and we took the best ideas we could find to put together this solution, which offers the hope of providing coverage to many of our uninsured and fixing one of Michigan's problems, which is we're unhealthy and we don't have access to care. So thank you, and at this